We're back at the ASH 2024 annual meeting. I'm Jeff Lancet, chair of the Department of Malignant Hematology at Moffitt, and joining me is Dr. Rami Komrokji, who is the vice chair of Malignant Hematology and also world-renowned MDS specialist. And Rami, tell us a little bit about, there's been a lot of really positive momentum in therapeutic advances in MDS over the last couple of years, changing the treatment landscape. Tell us a little bit about what has excited you here at ASH with some of the new therapeutic developments.
Absolutely. So first, thank you, and it's always a pleasure to be here with you another year. So so I think the landscape in MDS had changed, particularly the lower risk MDS. Actually, we've had made more progress. So now we have the luspatercept have moved to first line therapy, first time ever. And we got a drug that we actually at Moffitt were involved in developing, the Myelodysplastic, approved for patients at second line or high transfusion burden. We are starting to look at other erythroid maturating agents. There is a drug called Riltrecept that we will be leading the studies at Moffitt for also patients with lower risk. So really almost like two drugs approved, moving up front, and more to come. We still a little bit struggle with the higher risk MDS. Unfortunately, most of the recent studies with hypomethylating agent combination had not been positive, but we keep bringing more trials. But I think the highlights from the ASH this year will be really looking more at some of the Myelodysplastic data, looking at responses after other lines of therapy failure, looking more at long-term data from the commands using the luspatercept upfront.
And then another really, I think, exciting area of breakthrough is kind of the flood of new molecular knowledge in MDS and how that's changed the approach to this disease and how we not only diagnose it, but how we risk stratify it. And you've done a lot of work in understanding and developing the classification systems in MDS. Tell us a little bit about how the new classification systems are changing our approach to MDS.
Absolutely. So as you alluded to, we have newer classifications for all the myeloid diseases actually, where we have the World Health Organization or the WHO versus the international classification consensus kind of separated a little bit. And I think obviously we don't have time to go into the details, but where the things are moving into is like, first, we now recognize a lot of entities by molecular definition. So deletion 5q, SF3B1, P53, some abnormalities even in the setting of MDS became AML defining, like MPM1. So that's important. The other thing, the line between MDS and AML keeps changing. So now if you have 10% blast or more, we are calling those patients MDS/AML, which has pros and cons obviously, but it allows patients probably access to some of the drugs approved in AML. It does create some, obviously, more anxiety because nobody likes the term AML, it's usually more aggressive. And also it creates a little bit, controversy about the, eligibility for clinical trials response. But all over, I think it's a positive move that the line is really sometimes very arbitrary between MDS and AML. And also other type, I think where we are going to move eventually, we are going to move to a molecularly defined diseases. So if you have a biallelic P53, for example, whether you are calling this AML, MDS, MPN, the outcome for those patients is the same. And I think the next generation of trials and how we think of this should be geared that. So with that also, like those classifications had suggested, for example, CMML, the chronic myelomonocytic leukemia, to lower the threshold of the absolute monocyte count to less than 500 to less than 1,000, between 500 to 1,000, to consider that CMML. So what we did at Moffitt, we took a look at that, and if we really apply that, 25% of patients we classify as MDS today will be CMML. And that is important because that may make those patients not eligible for approved treatments now that they don't include CMML. If we are going to put patients on clinical trial, they will say they are not eligible for trial. So we took that group, we compared it to MDS patients, and we compared it to bona fide CMML patients, and we showed actually that 0.5 to 1,000 or 0.5 to 1 CMML is closer to MDS. So I don't think we are ready yet to make all the shift, or we have to be cautious because that have some implications. So it keeps evolving. It's a little bit, controversial and created a lot of dilemma for patients, for hematopathologists, for people that do clinical trials. But I think the move to classify all those myeloid diseases molecularly is very important.
Absolutely, and even if you can't change your treatment, it has significant impact on how we talk to our patients and what the prognosis may be, and helps patients understand their disease and plan better for the future. So exciting stuff. So thanks for being here.
Thank you. Always a pleasure. Thank you.